Hello, 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 ladies and gentlemen, and welcome. This is the first class, the first lecture of the new semester, and my first day with you, meeting you. So, welcome. Today we are talking about musculoskeletal disorders. So, the class outcomes, I noted the class outcomes in this PowerPoint for musculoskeletal disorders. It will also include the outcomes for musculoskeletal trauma. So if you're looking for class outcomes for musculoskeletal trauma in that PowerPoint, you're not going to find them because they are all here. So the outcomes for this class is to describe the potential complications that are associated with the patient in a cast or an external fixation and the nursing interventions to prevent them. Differentiate assessment findings in relation to significance and relief measures for chronic musculoskeletal disorders, utilize assessment findings in diagnosis and treatment in patients with fractures, sprains, and dislocations. We will apply the nursing process because we are nurses after all to the care of patients with degenerative joint diseases. And again, because we are nurses, we are going to utilize patient-centered care to formulate that care plan for the patient with hip replacement and ephemeral fracture repair. So, musculoskeletal disorders will impact our ability to move, and that may affect our ability to perform activities of daily living. Weakness, pain, or infection will affect our movement and or bone growth, bone strength, and may limit our ability to walk. Foot problems or foot pain is a common complaint with many causes, and it may impact negatively our ability to move freely. Nobody is happy when their feet hurt. So, muscular dystrophies, the epidemiology. Muscular dystrophy, otherwise known as MD, is a disease with many different subtypes that will affect certain muscle groups, are age specific in relation to presenting symptomology, have variations in severity, and are caused by a defect in different genes. They are classified as an inherited group of progressive myopathic meaning muscle disorders that are caused by imperfections in normal muscle function. Primary symptoms are progressive muscle weakening and wasting of skeletal or voluntary muscle groups. They can appear at any age from infancy until beyond middle age. So, the type and severity are partially determined by the age at the onset of the disorder, the disease. Some patients may have rapidly progressive muscle weakness and wasting, and they may pass away in their 20s. Others may experience mild, slowly progressive symptoms, and they may have a normal lifespan. The most severe forms are Duchenne and Becker. Duchenne muscular dystrophy, otherwise known as DMD, is the most well-known form and is the most common in children. Type N, I have moved on. Becker MD is also primarily prevalent in males and typically occurs in childhood. Myotonic dystrophy is the most common form of MD that is found in females. The inherited X chromosome is the only known associated risk factor. Pathophysiology of muscular dystrophy. It is caused by a mutation of the dystrophin gene. Dystrophin is a protein that is responsible for muscle repair. It is located on the plasma membrane of muscle fibers, and it will provide reinforcement and stabilization of the glycoprotein complex. The glycoprotein complex is a molecule that will contain carbohydrate and protein. So, in the absence or the reduction of dystrophin, the glycoprotein complex is digested by proteases, causing a degeneration of the muscle fibers, thus resulting in a muscle weakness. Primary commonalities are progressive muscle weakness, muscle wasting, and increased muscle enzyme serum levels. With the wasting and the breakdown of muscle, serum enzymes are elevated and are used in clinical practice to measure the extent of damage and or muscle deterioration. So some clinical manifestations of muscular dystrophy, there are 9 subgroups of MDs. Each will have a distinct clinical presentation, but all will present with progressive muscle weakness and chronic pain, notably in the lower back and the legs. So some clinical manifestations of muscular dystrophy are as follows. The 9 subgroups are as follows: Duchenne, Becker, myotonic, fascio-capillohumeral, limb girdle, oculopharyngeal, congenital, distal, and Emery-Dreifuss. With progressive deterioration and weakness of the fascial, limb, respiratory, and cardiac muscles, the end result is muscular damage. It is caused primarily by the lack of the key protein, again, that is dystrophin, to maintain the integrity of the muscle fibers, as well as the ability to repair muscle tissue when it breaks down or it becomes deteriorated. So because of muscle weakness, wasting, and weakness, falls are often associated with muscular dystrophy, which will put patients at risk for fractures. Progressive deterioration of facial muscles is associated with problems with dental hygiene, speech clarity, and articulation. As a result of immobility, gastrointestinal dysfunction is often associated with MD. The most life-threatening result of this progressive deterioration is the cardiopulmonary compromise that will occur as a result of the development of cardiomyopathy. Cardiomyopathy is a form of heart disease that will present with weakened heart muscle and decreased pumping ability, resulting in arrhythmias, shortness of breath, and then extreme fatigue. So, medical management, diagnosis. Diagnosis usually begins with a preliminary view of serum muscle enzymes such as CK, which is usually an early sign of the disease, and it will require frequent and close monitoring. Other serum enzymes such as LD, AST, and aldanase are elevated and frequently evaluated in clinical practice to monitor for muscle wasting and or deterioration. Recent literature will support monitoring serum creatinine levels as a differential diagnosis between Duchenne and Becker MD, as well as prognostic indicator of severity progression. So, other diagnostic studies, such as a chest x-ray, electrocardiogram, computed tomography, which is a CT scan, and electromyography, are frequently warranted to determine the extent of muscle wasting or the presence of cardiopulmonary compromise. The Muscular Dystrophy Association and Center for Disease Control and Prevention suggest early screening, diagnosis, and then intervention. A definitive diagnosis is often difficulties secondary to the fact that the clinical presentations may all be similar in nature. So, the gold standard is the muscle biopsy, in which a small piece of muscle tissue is extracted and examined for changes in the structure of the muscle cells. If MD is present, changes are visible and the biopsy can begin to detect the form of MD that is present. Diagnostic criteria for nearly all MDs now incorporate genetic testing. So, ladies and gentlemen, please listen up, and then listen up one more time. So, treatment of muscular dystrophy. Ladies and gentlemen, please pay attention. Medical management focuses on the prevention of the progressive deterioration of the disease. So, supportive measures to assist maximization of functional capacity and pain management. There is no specific cure or pharmacological intervention. What does this mean? This just means that we are going to treat the symptomology and perform nursing interventions as the situations arise. Glucocorticoid therapy is frequently the medication of choice in conjunction with supportive and collaborative care. However, practitioners need to be cognizant of the correlation of the high dose steroid usage and then the increased propensity to obesity. Please note. Ladies and gentlemen, please listen up one more time. Glucocorticoids such as prednisone have been shown to decrease the rate of muscle deterioration and increase restorative functional abilities. The pharmacodynamic principle of this therapy focuses on reduction of inflammation and regulation of metabolic pathways of proteins, carbohydrates, and fats, which will result in a decrease of the enzyme activity and reduced muscle destruction. Integrative therapies includes the use of supplements such as coenzyme Q10, carnitine, amino acids, anti-inflammatory medications, and antioxidants, in addition to corticosteroid therapy. Ladies and gentlemen, please note. In addition to steroid therapy, pain management is primarily done with Tylenol, aspirin, or ibuprofen. Psychosocial management is complicated and intensive. Often the stress associated with psychosocial management will exceed that of the physical aspects of the disease. So supportive care is necessary on a multi-level and multi-system perspective. Focus is adapting to the deterioration of physical capacities and overall changes in the roles and their functional abilities. So, a referral to the Muscular Dystrophy Association, otherwise known as MDA, for supportive services and genetic counseling information is very highly recommended. Complications of muscular dystrophy: spinal deformity and neuromuscular deterioration causing weakness of the trunk and lower extremities are severe complications. With the development of scoliosis. Scoliosis is the curvature of the spine. So with the development of scoliosis and overall thoracic lumbar changes, respiratory and cardiac compromise can develop. Total contact orthotic devices that support the trunk can assist with minimization of spinal deformity and support cardiovascular function to prevent cardiac compromise that can occur with progressive MD. Ineffective cardiovascular and pulmonary functions are additional life-threatening complications that can result with progressive MD. So nursing management assessment and analysis. Many clinical manifestations observed in patients are directly linked to the progressive muscle weakness and wasting that occur at the neuromuscular level. So some common findings will include weakness that will affect the proximal before the distal limb muscles, difficulty with running, jumping, and then walking upstairs. Lumbar lordosis. Lumbar lordosis is excessive inward curvature of the lumbar spine, and calf enlargement. Cardiomyopathy, especially involving the avioventricular node, the AV node, and then later cardiovascular disease associated with cardiomyopathy, such as heart failure, left ventricular heart failure to be specific, respiratory compromise, falls leading to fractures, and depression. So, some nursing diagnoses for muscular dystrophy: impaired physical mobility associated with decreased muscle tone in the lower extremities, as evidenced by the inability to walk independently. Risk for dysphagia associated with decreased facial movement and or cranial nerve 7 dysfunction. Risk for falls associated with decreased muscle tone in the lower extremities. Risk for decreased cardiac output associated with AV node dysfunction. Risk for ineffective breathing patterns associated with lumbar posture deformity. So, nursing interventions for muscular dystrophy. We are going to assess, because we are nurses, we are going to assess vital signs, heart rate, blood pressure, and pulse ox. Increased heart rate, decreased blood pressure, and decreased SpO2 may indicate deterioration of cardiovascular and respiratory status. We are going to assess forced vital capacity. We are going to look at a chest x-ray. A changing chest x-ray will indicate potential for respiratory compromises due to changes in skeletal structure. Laboratory enzymes: increased CK, LD, AST, and aldose lactate levels indicate muscle deterioration and breakdown. Increased serum and 24-hour urine creatinine clearance levels indicate differential diagnosis and severity of muscle deterioration and disease progression. So, electrocardiogram: avioventricular node disturbances indicate changes in cardiac electrical activity and can be indicative of cardiac compromise. So, nursing actions for muscular dystrophy. We are going to administer corticosteroid therapy as doctor orders. For pain management, we can administer aspirin, ibuprofen, Tylenol as ordered for pain control. Range of motion exercises. We are going to put this patient on fall precautions. Because of increasing weakness, the patient will be at an increased risk for falls and fractures. Collaborative care with occupational therapy, physical therapy, and a rehabilitative medicine team. So, teaching for muscular dystrophy. We will reinforce exercises and physical and occupational therapy regimens, and we will consider family members and recognize signs of caregiver burden. Most patients will be cared for at home, even as they progress to a very dependent and or ventilator state as a result of cardiopulmonary compromise. Increasing dependency on family members can cause caregiver strain and burden. Family members should be taught to recognize these symptoms and recognize the need to contact supportive services, such as the MDA, to provide respite care when needed. And we will also counsel them on genetic counseling. And then evaluating care outcomes for muscular dystrophy. How do I know that I did a good job taking care of this patient? The ultimate outcome is to promote and maintain optimal levels of function and comfort and a prescribed quality of life within the limitations of the disease. Supportive and collaborative care for both the patient and the family is an essential component of nursing care, promoting maximal wellness in the patient and controlling caregiver burden. Disability is the greatest fear of this population, so supportive and psychiatric care are essential to the holistic nursing approach. Osteoporosis. Osteoporosis, ladies and gentlemen, please listen up, and then listen up one more time. Osteoporosis is a chronic condition that will result in deterioration of bone tissue and density, increasing risk for fractures. It is the most common bone disease. Risk factors are defined as primary and secondary. Primary risk factors are those that are non-modifiable, such as age or race, and lifestyle choices such as sedentary lifestyle, not enough calcium intake, or smoking. Please continue to listen up, ladies and gentlemen. Please take note. Secondary risk factors will include other disease states that are associated with an increased risk, such as Cushing's disease or medications such as steroids. Although not totally understood, Down syndrome is also associated with an increased risk, potentially associated with the accelerated aging that is associated with that syndrome. Ladies and gentlemen, please listen up. On table 53.3, on page 1205, there is a table, primary and secondary risk factors for osteoporosis. Ladies and gentlemen, you will please know this table. Pathophysiology for osteoporosis. Bone is a living, growing tissue that constantly forms new bone while replacing older bone through a process called bone remodeling. It is maintained by two types of bone cells, osteoclasts and osteoblasts. Osteoclasts break down bone by adhering to the surface of the bone and secreting acids and enzymes that are directly into the bone cavity. Osteoblasts will rebuild the bone by synthesis and mineralization of the new bony matrix within the bone cavity. Bone loss is referred to as osteopenia. So bone loss will occur when the bone reabsorption, and this is the osteoclastic activity. So the osteoclastic activity is greater than bone rebuilding. Bone rebuilding, again, is the osteoblastic activity. And this will ultimately result in a decreased bone mineral density, otherwise known as BMD. So the resulting bone loss causes changes in the skeletal structure and results in an increased risk for fractures. So some important factors to note that occur with aging are a decrease in calcitonin levels, and this is a hormone that will decrease osteoclastic activity. A decrease in estrogen level, which results in the inhibition of bone formation. An increase in the parathyroid hormone, which will increase osteoclastic activity and turnover. All of these changes will produce a decrease in BMD, bone mineral density. Bones become more porous, brittle, and fragile, increasing the risk for fracture. Areas of bone loss are associated with vertebral changes in the lumbar spine and hip fractures and cause fracture of the wrist. Clinical manifestations of osteoporosis. Osteoporosis is frequently referred to as a silent disease, secondary to the fact that patients are not diagnosed until a fracture occurs after an unremarkable fall or strain. Fragility fractures most often occur in the spine, hip, and distal radius. So prevention is the key modifying factor to incorporate into the medical care for patients at risk for osteoporosis. So, medical management of osteoporosis. Universal recommendations are annual height measurements with a preferred wall-mounted stadiometer. The gold standard assessment is BMD measurements for women over the age of 65 or for men over the age of 70 and for postmenopausal women. Men 50 to age 69 with a high risk factor profile. Medical management. Diagnosis is obtained through a dual energy X-ray absorptiometry, otherwise known as a DEXA scan. A DEXA scan will give precise measurements at clinically relevant skeletal points within the body, which will highlight areas for future fracture risks. The DEXA scan reports T-scores of the standard deviation above or below the mean for healthy young individuals. So a low BMD, one is that is 2.5 standard deviations or more below the mean for a young adult person, is highly correlated with an increased risk for fractures. A BMD that is low, but not at the level of osteoporosis, is indicative of osteopenia, and that is a precursor for osteoporosis. Another assessment tool, quantitative computed tomography, otherwise known as a QCT, measures volumetric bone density of the spine and hip and can identify critical and trabecular bones. This tool is not recommended for screening, but for diagnostic management. Literature also supports the use of ultrasonography as a good predictor for fractures and osteoporosis risk for both men and women. The major limitation of this diagnostic tool is associated with limited precision. So, although there is no definitive laboratory test to confirm osteoporosis, biochemical markers are helpful in providing insightful information associated with the status of bone remodeling. An important step in assessment is fracture risk assessment screening, and the most widely used tool is the Fracture Risk Assessment Tool, otherwise known as FRAX, F-R-A-X, which was developed by the World Health Organization's Collaborating Center for Metabolic Bone Disease. The FRAX will use clinical risk factors with or without BMD to assess a person's 10-year risk for the development of fractures. This tool collects information on numerous key issues and associated clinical risk factors, and then calculates a 10-year probability for hip and any one of the 4 major osteoporotic fractures. The medical convenience of the FRAX tool is the ability to link directly to the National Osteoporosis Guideline Group algorithms and guidelines for clinical management. The FRAX tool is not used for patients under the age of 40 or over the age of 90. Because of the silent nature of the disease, X-rays are not commonly used for screening and assessment, and it is estimated that a change of greater than 25 to 40% in demineralization of the bone would need to be evident to be detected on an X-ray. So, treatment of osteoporosis. Prevention and early prevention and early screening are the focus, Weight loss and muscle strengthening exercises to reduce the incidence of falls and fractures are highly recommended. A healthy lifestyle that includes weight-bearing exercise that helps build and maintain strong bones, and avoidance of smoking and excessive alcohol intake. Alcohol intake is considered more than 3 drinks per day, are endorsed as a means of prevention. So, medications for osteoporosis. Pharmacological intervention is focused on preventing and slowing the progression of bone loss. The first line of prevention is safe and inexpensive with the use of calcium and vitamin D. Vitamin D helps with calcium reabsorption with the intestines and assists with the maintenance of adequate serum calcium levels that are imperative for bone health, muscle performance, and then decreased risk of falls. Sunlight for 15 minutes per day helps with vitamin D and calcium absorption. Ladies and gentlemen, please listen up, and then listen up one more time. The Food and Drug Administration has approved medications for prevention and to decrease fracture risk. Practitioners are encouraged to assess the potential benefits versus risk for each individual patient. Ladies and gentlemen, please listen up. On page 1207 in your textbook, there is the table 53.5, pharmacological interventions for the treatment of osteoporosis. Ladies and gentlemen, you will know this table. Complications of osteoporosis. Complications surround the skeletal changes that occur as a result of bone loss and then the lack of bone remodeling. Patients are more at risk for falls, which carries a greater risk for fractures. All fractures in older adults can result in a higher incidence of prolonged hospitalization and then untimely death. Nursing management of osteoporosis. Many of the clinical manifestations are directly associated with a decrease in bone reabsorption and then bone rebuilding, which can lead to osteopenia. Again, osteopenia is bone loss. Some common findings will include the dowager's hump, that is kyphosis of the dorsal spine, loss of height 2 to 3 inches, back pain that is either sharp or acute, pain that is increased with activity and then relieved with rest, restriction of movement, especially in the thoracic and then lumbar regions. Fear of falling. Fear of falling is called fallophobia and or a history of previous falls, previous fractures. Other clinical manifestations include constipation, abdominal distension, and reflux esophagitis. All are associated with a decrease in movement and spinal deformity. And then potential respiratory complications are due to curvature of the spinal column and decreased chest excursion. Some nursing diagnoses for osteoporosis: risk for trauma associated with bone loss and the potential for falls and or fractures, impaired physical mobility associated with pain and musculoskeletal changes. Nursing interventions for osteoporosis. We're going to assess fall risk, age and change in skeletal structure, bone loss and a decrease in BMD can result in deformity and disability, which are correlated with the potential for falls and fractures. We're going to assess pain. The presence of pain can decrease mobility and optimal functioning. We are going to assess nutritional status. We will assess the level of activity and exercise, and then body image disturbance. Skeletal changes can cause issues associated with posture, again, that kyphosis, and difficulty with clothing fitting appropriately. Physical appearance can change and cause issues associated with self-esteem. Some nursing actions for osteoporosis. We could administer one of the following medications as ordered: bisphosphonates, calcitonin, estrogen hormone therapy, an estrogen agonist or antagonist, parathyroid hormone, parathyroid hormone analogs, a dual acting bone agent, and then monoclonal activities. We will support exercise programs, implement steps to correct or supplement underlying physical and functional deficits, provide training for safe movement and with activities of daily living. And we can also contact a home health agency for a home environmental safety evaluation. This population is at high risk for falls and fractures, so the home environment needs to be evaluated for environmental and safety hazards. And then teaching for osteoporosis. We are going to instruct to take medication as prescribed. Many of the bisphosphonates need to be ingested first thing in the morning on an empty stomach. They can cause GI disturbances, esophagitis, and visual disturbances. These side effects need to be reported to a provider as soon as possible. We will instruct patient in weight reduction if that is necessary, and instruct patient to incorporate adequate ingestion of vitamin D and calcium, and then evaluating care outcomes for osteoporosis. Patients can live a functional and safe lifestyle if best practice standards are followed and maintained. Evaluative outcomes focus on early identification of the risk for fracture. Education and support for patients with dietary and lifestyle issues, as well as education and discussion surrounding bone-sparing medications, such as the bisphosphonates, are essential. And then persistence with a healthy lifestyle and monitoring of the treatment regimen have been shown to be highly effective. Osteomyelitis. Osteomyelitis, the incidence and prevalence is directly linked to the mechanism of infection, hematogenous, or non-hematogenous. Hematogenous or endogenous osteomyelitis is a result of infection spread from another area of the body via the bloodstream. Non-hematogenous or exogenous osteomyelitis is a result of an open fracture and/or trauma to the bone. Acute hematogenous osteomyelitis is more commonly seen in children and those less than 1 year of age. Non-hematogenous osteomyelitis is more commonly associated with adults and open surgical fractures or a trauma. It is the most common with metaphysicists of long bones, such as within the femur, tibia, or humerus. Trauma is the leading causative factor, which tends to affect males between the ages of 18 to 30 years. It can also be linked to other causative factors such as implanted surgical devices and then puncture wounds. Osteomyelitis is classified into one of three categories: acute infection, which is less than 2 weeks; subacute infection, which is from 2 weeks to 3 months; and then a chronic infection, which will last longer than 3 months. Diabetes and foot puncture prevalence statistics for chronic osteomyelitis can range as high as 30 to 40%. The pathophysiology of osteomyelitis. The pathophysiology for acute and/or chronic osteomyelitis is complex and not always understood. In both acute and chronic osteomyelitis, the process begins with an invasion of the bone and surrounding tissue by one or multiple bacterial pathogens. This leads to inflammation, and this results in edema. Within days to weeks, a thrombus occurs in the vessel, which leads to ischemia and slow necrosis of the affected area and bone. So, the pathophysiology of osteomyelitis is being continued. Once necrotic bone is present, healing is delayed, and a superimposed infection or abscess is highly probable. This results in a cycle of more inflammation and infection. The ultimate clinical hallmark is bone necrosis and the development of sinus tracts between the bone and the skin. Exogenous osteomyelitis can be from trauma and/or surgery, in which the bacterial spread is via direct inoculation from a fracture or an open wound, or contagious spread from a contagious wound. Endogenous is caused by the spread of an infection from one area of the body to another because of infections in adjacent soft tissue and joints or indirect inoculation. Older adults are affected by contagious osteomyelitis, in which the infection spreads to bone. Staphylococcus aureus, coagulase negative staphylococci, and aerobic gram negative bacilli are the most common pathogens found in litigious osteomyelitis. Clinical manifestations of osteomyelitis. Acute clinical manifestations include pain that is not relieved by rest, swelling, tenderness, and warmth at the site, fever, nausea, chills, and a general feeling of being unwell. And a general feeling of not feeling well is what we term malaise. Chronic clinical manifestations include constant bone pain, edema, tenderness, erythema, and then warmth at the site. So, medical management of osteomyelitis and then diagnosis. Diagnosis can be difficult secondary to the fact that many serum laboratory tests are nonspecific. A white blood cell, which is a WBC count, ESR blood cultures, and a C-reactive protein, a CRP, these levels are the initial steps for diagnosis. White blood cells will be elevated due to the infection. The ESR and the CRP levels are indicators of inflammation. A positive blood culture with evidence of soft tissue edema, bone degeneration, and a positive periosteal elevation. A periosteal elevation is when the bone is enlarged due to pus formation. So a positive periosteal elevation is considered enough conclusive data to confirm a diagnosis of osteomyelitis. So ladies and gentlemen, listen up, and then listen up one more time. A bone scan is the test of choice for acute osteomyelitis. An increased uptake of radioisotope to the infected bone can detect an infection within 2 to 3 days of the beginning of the infection. Computed tomography scans and magnetic resonance imaging and MRI is useful tools to assist with diagnosis. However, ladies and gentlemen, a bone biopsy is the gold standard for a conclusive diagnosis. An open approach, which is the preferred approach, so an open approach or a needle aspirate can be used for this procedure. A positive biopsy of the infectious bone is conclusive for both acute and chronic osteomyelitis. Ladies and gentlemen, please take note. So, medications for osteomyelitis. Due to the complex nature of osteomyelitis, a collaborative medical management team is highly recommended. Medical management requires clinically appropriate antibiotic therapy and surgical debridement and incision of the infected and/or necrotic tissue and bone. The antibiotic regimen is based on culture and sensitivity results. Age, renal function, and health status are important criteria in the antibiotic selection. The initial line of treatment is antibiotic IV infusions over a course of 4 to 6 weeks from the time of the first surgical debridement. A surgical debridement is the surgical cleaning of the wound. Beta-lactam antibiotics such as penicillin and cephalosporins are the first line options unless methicillin-resistant Staphylococcus aureus, otherwise known as MRSA, is suspected. If MRSA or an allergy to penicillin, then intravenous vancomycin is the medication of choice. Fluoroquinolones are an alternative for Staphylococcus infections and have been shown to be highly successful because of their bone-penetrating ability. Intraoperative antibiotic bead placement with severe and/or chronic osteomyelitis has been shown to be therapeutic and effective. Opioid analgesia is indicated to manage the pain. Nutritional support will focus on a high-protein diet to support and aid in the wound healing. So, surgical management of osteomyelitis. Surgical intervention with debridement is required when a patient demonstrates one of the following: failure to respond to antibiotic therapy, evidence of soft tissue abscess or periosteal collection, suspected or confirmed joint infection, progressive neurological deficits, or spinal instability. In the event a patient has known or suspected infected orthopedic hardware, then surgical removal of that hardware is warranted. In most extreme cases, a surgical amputation is performed to promote healing and vascular supply to healthy tissue and the bone proximal to the infection. So, complications of osteomyelitis. In the absence of appropriate therapy and medical management, disabling and life-threatening complications such as sepsis, potentially resulting in amputation. Squamous cell carcinoma, along with other tumors such as fibrosarcoma, myeloma, lymphoma, plastocytoma, angiosarcoma, and rhabdomyosarcoma, are also complications. Prompt diagnosis and early treatment with antimicrobial therapy is essential. So, nursing management of osteomyelitis. Many of the clinical manifestations observed in the patient are directly associated with the pain and the extent of the infection within the bone and the surrounding tissue. So, some common findings will include a fever greater than 101, especially when a bloodstream-borne infection is present. Pain can be defined as constant, localized, with pulsating tenderness, swelling, erythema, and warmth to the affected area, irritability, general malaise, and then lethargy. Difficulty moving joints near the affected area, difficulty bearing weight on the affected area, poor perfusion to the area as demonstrated by venous stasis ulcers, and then stiff back that will demonstrate a vertebral involvement. So, some nursing diagnoses of osteomyelitis: acute chronic pain associated with inflammation, impaired physical immobility associated with pain and inflammation, peripheral neurovascular dysfunction associated with impaired perfusion to the affected extremity, risk for disturbance to body image associated with skeletal changes and bone deformities. So, nursing interventions for osteomyelitis, we are nurses, so we assess and we will assess temperature, pulse, and blood pressure. An elevated heart rate, decreased blood pressure, and febrile, that is a fever, may indicate an infection. Pain, increased pain may indicate activation of the inflammatory process. Pain unusual to the illness can be indicative of infection. And then wound assessment, redness, heat, purulent drainage, pain and edema are all signs of a wound infection. Neurovascular assessment. Weak pulses, pallor, pain, paresthesia, and or paralysis will indicate impaired circulation, which will require prompt intervention to avoid disabling complications due to decreased blood flow to the affected area. Laboratory tests, again, the WBC, the ESR, the CRP. An increased WBC, ESR, and CRP are indicators of infection and inflammation. Blood cultures, wound cultures, positive blood cultures, and or wound cultures definitively diagnose infection and determine the appropriate antibiotic. So, some nursing actions for osteomyelitis: we will administer IV antibiotics as ordered. Because of the severity of the infection and the potentially disabling complications, IV antibiotics are indicated and they will be continued for 4 to 6 weeks. We will administer analgesic therapy as prescribed. We can apply thermal therapy as ordered, apply gentle range of motion exercises to the joints above and below the affected site. We can provide training for safe movement with activities of daily living. This patient population is at great risk for falls with transfers and lifting. So we need to use assistive devices when appropriate. We can provide nutritional support, and we can contact a home health agency for home infusion antibiotic therapy. So some teaching for osteomyelitis, some patient education. We can educate to take the pain analgesic medications as prescribed. Pain control is essential to encourage mobilization. Opioids are very addicting and can cause constipation, drowsiness, and respiratory depression. Patients should be educated not to drink alcohol or drive while taking opioids. We will educate to take prescribed antibiotics and complete a full prescription, take the full course to avoid a rebound or resistant infection. And we can instruct the patient on nutritional therapy to incorporate a high protein diet. So, how do I know that I've done a good job taking care of this patient with osteomyelitis? Focus is on control of pain, resolution of infection, and limb preservation. Adherence to the IV antibiotic regimen is essential to avoid complications such as a bone abscess, a fracture, bacteremia, delayed bone healing, gangrene, and ultimately amputation. Early recognition and prompt treatment are essential for effective clinical management and reduction of potential complications. And a well-managed patient has pain and infection under control and retained limb functionality. So, bone cancer. Bone cancer is subdivided into two classifications: benign bone cancers, which are non-cancerous and often asymptomatic, and malignant, which are cancerous in nature and originate either from a primary or a secondary source. Primary bone tumors are more prevalent between the ages of 10 and 30 years and are generally seen in only a small percentage of the population. Secondary or metastatic lesions are more often diagnosed in the older population. Osteochondroma is a benign bone tumor, is the most common form of bone cancer, and is seen at the end of a long bone, such as the knee or the shoulder. Ewing sarcoma, a primary bone cancer, is most common in children and is the most malignant and deadly of all cancers. So, the epidemiology of bone cancer: osteosarcoma is rare. It is the fifth most common malignancy among adolescents and young adults. It is found twice as often in males than in females between the ages of 10 and 30 years of age, and the overall prognosis is very poor. Metastasis to the lungs, and if it occurs, can be seen within 2 years from the time of diagnosis, and then ultimately will result in death. And some risk factors are prior radiation and or chemotherapy. So, pathophysiology of bone cancer: the actual etiology is not exactly known. One theory is that osteosarcoma arises from rapid or abnormal bone growth and remodeling that is triggered by an oncogenic agent during a time of cell proliferation or growth. This may explain why it is common in in children and adolescents. The underlying pathology of the tumor of the bone is a disruption in either the osteolytic response, which is bone destruction, or the osteoblastic, which is bone growth actively within the bone tissue. Osteosarcomas are associated with a production of osteoid or immature malignant bone cells. These are seen where the bone is growing quickly, such as near the ends of the long bones in the distal femur, the proximal tibia, or in the proximal humerus. So, some clinical manifestations of bone cancer. Clinical manifestations are common to those of other musculoskeletal health problems, and this can delay diagnosis. The following manifestations may be present at the tumor site: pain worse with motion and unrelieved by rest, pain that may result in a lump, swelling, redness, decreased range of motion, a fracture. Medical management of bone cancer. The primary evaluative tool is a comprehensive history and physical examination focusing on the musculoskeletal system. The past medical history focuses on exposure to previous radiation and/or chemotherapy. Following the history and physical, diagnostic studies including CT, bone scans, myelography, arteriography, MRI, a bone biopsy, and biochemical analysis of the bone and urine are recommended. Ladies and gentlemen, please listen up, and then listen up one more time. Serum alkaline phosphatase, LD, and ESR levels are frequently elevated due to the increased enzyme activity at the level of the muscle, the deterioration of the bone, and the inflammatory response. With metastasis from the breast, kidney, or lung to the bone, elevated calcium levels are frequently noted. MRI is superior to CT due to the ability to define the extent of soft tissue involvement, neurovascular compromise, joint and marrow involvement, and the presence of metastasis. Ladies and gentlemen, please take note. Treatment of bone cancer. The primary objective of medical management is to destroy or remove the tumor. The ultimate goal for treatment is limb salvation, survival, and maintenance of quality of life. Treatments can range from radiation therapy, if the tumor is radiosensitive, to chemotherapy, to surgical incision. Radiation therapies such as brachytherapy, which is internal radiation, or external radiation treatment, is used if the tumor is radiosensitive. In the case of primary bone tumors, radiotherapy is used to destroy or reduce the size of the tumor so that chemotherapy and/or surgical excision can be used. Radiation therapy can be scheduled for one session or multiple sessions, depending on the radioactive treatment response. Chemotherapy is another treatment alternative. The goal is to reduce and/or destroy the bony tumor to prevent metastasis. Essential to the successful eradication via chemotherapy is early identification and treatment. Treatment must be initiated when the disease burden is low. Most tumors, as well as other bone tumors, use a multimodality treatment approach, multiple chemotherapeutic agents, and/or a combination of radiation and surgical intervention. Pain control is a significant goal of treatment. Treatment includes non-steroidal anti-inflammatories such as acetaminophen. Narcotics are necessary to manage pain. So, surgical management of bone cancer is focused on resection of the cancerous mass and limb salvation. For most bone tumors, radical resection, removal of the mass, the entire muscle, bone, and other surrounding tissues that have direct involvement with the lesion is performed. The focus of this approach is limb salvation and the prevention of metastasis. Some complications of bone cancer. In the absence of appropriate therapy and medical management, neoplasms of the bone are associated with disabling and life-threatening complications such as amputation and death. Other complications after surgery include delayed wound healing, osteomyelitis, and wound infections, and hypercalcemia. So, nursing management of bone cancer. Many of the clinical manifestations are directly associated with the pain and the extent of the cancer to the bone and surrounding tissues and organs. Most common sites are the distal femur, proximal tibia, proximal humerus, and middle and proximal femur. Common findings will include localized pain, commonly over several months' duration, pain frequently noted with incurrence of injury, and this may come and go over time, a soft tissue mass that is large and tender on palpation. Other clinical manifestations such as fever, malaise, and weight loss are associated with metastasis and are not normally seen with primary bone cancer diagnosis. So some nursing diagnoses for bone cancer: acute chronic pain associated with destruction of bone, impaired physical mobility associated with pain and inflammation, peripheral neurovascular dysfunction associated with impaired perfusion, ineffective tissue perfusion associated with inflammation, grieving associated with impaired body image, and this would have to do with loss of limb if we were unable to salvage the limb. Risk for pathologic fractures associated with destruction of the bony matrix. So some nursing interventions for bone cancer. We will assess. We're going to assess the respiratory rate and level of consciousness. Bone cancer requires aggressive pain management. So a decrease in respiratory rate or level of consciousness may indicate that the patient is over-medicated. We will assess their pain. We will do a neurovascular assessment. Weak pulses, pallor, pain, paresthesia, paresis, and or paralysis indicates a compromise in neurovascular status that may be caused by compartment compromise. This is increased pressure in the tissues that are surrounding the mass, and this can result in loss of muscle, tissue, nerves, and bone. Palpation of mass. A palpable mass with swelling, pain, and tenderness may indicate a progression of tumor growth and then metastasis. So we will assess level of activity, exercise, and independent function. Independence versus dependence is a potential problem for patients with bone cancer. Pain and the disability caused by osteosarcoma may limit the ability to perform activities of daily living independently. So, some nursing actions for bone cancer. Administration of pain medication as ordered. Pain is extensive and requires aggressive pharmacological intervention. We will monitor vital signs of patient for opioid-induced respiratory depression. With the work of the healthcare team, we will support long-term pain relief, pharmacological, and then also using non-pharmacological therapies. Prepare and support the patient for radiation treatment if warranted. Be sure patient is free from moisture, deodorants, and creams. Moisture, deodorants, and creams may cause radiation skin irritations and burns. We will administer chemotherapeutic therapy as ordered. We will support and position the affected extremities with gentle range of motion and exercises to the joints above and below the affected site. Bone tumors will weaken the bone, causing extreme pain on movement. Exercises for pain relief and external supports are used for additional support, comfort, and patient safety. Apply thermal therapy as ordered from rehabilitative services. So, teaching for bone cancer, patient education, we will educate the patient to take pain analgesic medication as prescribed. Adequate pain management is essential to promote maximal independent functioning. Opioids are addictive and can cause constipation, drowsiness, and respiratory depression. Patients should not drink alcohol or operate a car under the influence of these medications. Teach the patient about radiation therapy. Radiation therapy can cause localized skin irritation. The skin can blister and may appear sunburned. Teach the patient to eat a diet rich in protein. A high protein diet will help with tissue and wound healing. Provide training for safe movement with activities of daily living. This population is at great risk for pathologic fractures causing falls. Patient understanding of disease process and symptom management, onset and course of therapy of injury and illness. So, evaluating care outcomes for bone cancer. How do I know that I've done a good job? Limb salvation and prevention of metastasis are the essential components of a well-managed patient. Effective pain management facilitating an optimal level of independence are paramount for patient comfort. Early recognition of symptoms is of key importance because it allows early initiation of treatment with radiation, chemotherapy, and/or surgical excision. Ladies and gentlemen, thank you so much for your time and for listening. And please reach out with any questions, comments, concerns, or issues if you think I can be of help.